Today we are going to talk about dental update article about special care dentistry and general anesthesia. This is the part 2 of the series of these articles. Part 1 published in last year's issue of December. Is it important? The scope of this article is if you are going for registration exams such as Australian Dental Council exam or GDC, ORE or LDS exam, then it is going to be important for you as it is considered basic knowledge or advanced knowledge of a general dentist. But if you are going for any specialization or you are doing any specialization, then most of the content in this article you will already know. The building blocks of this article are pre-anesthesia and administrating the anesthesia, delivering the dental care, and post-op anesthesia. In pre-anesthesia care, we are going to talk about some scheduling. That scheduling should be done early in the morning so that patient can go home when they are recovered from anesthesia in the evening or preferably at night. The pre-medication required is generally for some anxiety the patient has. The recommended agents for anxiety are non-pharmacological agents. For example, you might familiarize the patient with the premises of the place where he is going to get the treatment under GA and the room he is going to be staying in before and after the general anesthesia. The pre-medication agents used here are lorazepam, but preferred agent is midazolam, either orally or nasally. Nasally has a faster onset of action, and if they are not being used, then we are going to use alpha-2 agonists such as clonidine or ipratropium, but these require specialist care. Another agent used here, mentioned in the article, is promethazine. For IV cannulation, to provide some cause of pain management, we are going to use EMLA cream that has an onset of action in 30 to 60 minutes. Clinical holding mentioned here in the article is the trained medical staff or your dental team stabilizing the patient's arm for IV cannulation, or they are holding the patient when they are undergoing the general anesthesia. Coming to the first part, administration of general anesthesia. The administration of general anesthesia requires either one of the approaches, either gaseous anesthesia or intravenous anesthesia, or a mixture of these. Gaseous anesthesia mostly consists of nitrous oxide and sevoflurane, and if we are going for mixed approach, the propofol is used as induction agent, then continued with sevoflurane. In total intravenous anesthesia, we are going to induce with propofol as before, and we are going to continue with short-acting opioids such as remifentanil. Desflurane was very popular due to its rapid onset of action and rapid withdrawal and finishing of anesthesia, but it has high air pollution potential such as 2500 times that of carbon dioxide. This slide shows that there are two types of the apparatus we are going to use for maintenance of the patent airway. First of them is laryngeal mask airway that requires less plane of anesthesia and less traumatic to the patient and sits as a cuff over the epiglottis or vocal cords, while the other one is a definitive airway, requires a deeper method of anesthesia and is called endotracheal tube. The endotracheal tube causes sometimes bronchospasms or bleeding or trauma or a cough after the patient has recovered from anesthesia. While the patient is under anesthesia, there is intraoperative management of patient such as his blood pressure, his pulse oximetry, his carbon dioxide pressure, his ECG and his EEG. EEG is used when we are using IV method of anesthesia to maintain and gauge the depth of anesthesia patient is under in, that is called bispectral index. When patient is under anesthesia, the metabolic rate is decreased by 40% and there is vasoconstriction, so the patient is undergoing hypothermia. Warming methods are generally needed because if it is not addressed, the coagulation cascades will be disturbed and patient will go internal bleeding. Second part is the provision of dental care. what type of dental care that can be provided under general anesthesia. There are several factors such as patient preferences, patient oral hygiene status, patient's occlusion, and prognosis of patient's dentition. And first of the things we are going to do under general anesthesia is intraoral radiographs, preventive oral hygiene according to patient's oral hygiene status, application of sealants and fluoridation of the teeth. The second part is we are going to provide him with prosthesis and some orthodontic prosthesis such as Essex retainer. Prosthesis can be done if the patient has missing anterior teeth. We can provide him with resin bonded bridges. Restoration and root canals can be done for anterior teeth provided the caries of the teeth extends only to enamel or dentine. Root canal can be done for those teeth that require they are discolored and require bleaching, so we provide them with root canal and do non-vital bleaching. Finally, we are going for extractions. Extractions are primarily indicated for third molars who are at risk of causing caries in second molars and that teeth which have undergone root fractures, and the elements such as BTRs or things like these. In the next section, we are going to talk about post-operative management. Now the patient is coming out of anesthesia. He can have significant pain due to the operative procedures. We are going to provide him with the local anesthetic that is long acting such as bupivacaine or ropivacaine. We are providing him with the orientation to his surroundings as the patient is coming out of general anesthesia. He might be disoriented or confused. So we orient the patient to the time, the place and introduce ourselves such as who has done the treatment and what their role was in the management. Then we provide the patient and their care with verbal and written indications. Thank you for watching to our video. Do comment, like and subscribe.